What is the first-line treatment for symptomatic bradycardia, and under what conditions should it be administered? Answer. Symptomatic bradycardia is defined as a heart rate that is too slow, typically 60 bpm, and is causing symptoms such as chest pain, altered mental status, hypotension, or signs of shock. The first-line treatment is atropine, an anticholinergic drug that blocks vagal influences on the heart, resulting in increased heart rate. Initial dose: atropine 0.5 mg IV push, repeated every 3-5 minutes as needed up to a total maximum of 3 mg. Indications: atropine is indicated when bradycardia is causing symptoms of hemodynamic instability, such as hypotension, systolic blood pressure 9 mmHg, altered mental status e.g. confusion or loss of consciousness, signs of shock e.g. cool, clammy skin, acute heart failure, chest pain due to myocardial ischemia. Mechanism of action: atropine works by inhibiting the effects of the vagus nerve on the heart, allowing for increased automaticity of the sinoatrial SA node and conduction through the atrioventricular AV node. If atropine is ineffective or the patient is severely unstable, additional treatments include transcutaneous pacing, external electrical stimulation to maintain heart rate, dopamine infusion, 2,1-neuraminidine for patients with symptomatic bradycardia and low blood pressure, epinephrine infusion, 2,1-neuraminidine as an alternative to dopamine. Explain the difference between rate control and rhythm control in the management of atrial fibrillation. Answer. Rate control and rhythm control are two approaches for managing atrial fibrillation AF. The choice between the two depends on the patient's symptoms, duration of AF, comorbid conditions, and overall cardiac function. Rate control focuses on controlling the ventricular rate rather than restoring normal sinus rhythm. The goal is to reduce the heart rate to prevent symptoms such as palpitations, dyspnea, and to reduce the risk of heart failure. Target heart rate: generally the goal is to maintain a ventricular rate of 60-100 bpm at rest and 110 bpm during activity. Medications: beta blockers e.g. metoprolol decrease heart rate and reduce myocardial oxygen demand. Calcium channel blockers e.g. diltiazem, verapamil control heart rate by slowing AV node conduction. Digoxin, sometimes used for patients with heart failure but is not first-line therapy for rate control. Indications: often used in patients who are asymptomatic or have minimal symptoms, elderly patients, or those for whom rhythm control is difficult to achieve. Rhythm control aims to restore and maintain normal sinus rhythm. Rhythm control can be achieved via pharmacologic agents or electrical cardioversion. Pharmacologic options: amiodarone, effective antiarrhythmic but with potential for significant side effects. Flecainide, propafenone, used in patients with no structural heart disease. Dofilide, sotalol. Other antiarrhythmic options based on the patient's cardiac profile. Electrical cardioversion, direct current DC cardioversion, may be used to quickly restore sinus rhythm, especially in unstable patients. Indications: younger symptomatic patients, those with first episode AF, or those with heart failure where maintaining sinus rhythm can improve cardiac function. Mr. Thompson is a 68-year-old male who presents to the emergency department with chest pain and shortness of breath. ECG shows wide QRS complexes at a rate of 160 bpm. What immediate interventions should be considered for Mr. Thompson and why? Answer. In Mr. Thompson's case, the wide QRS complexes at a heart rate of 160 bpm indicate the presence of a ventricular tachycardia VT. VT is a potentially life-threatening arrhythmia that requires immediate attention. Initial assessment: assess for hemodynamic instability. Check if the patient has hypotension, altered mental status, or other signs of instability. Hemodynamically unstable VT is treated differently than stable VT. Management: if hemodynamically unstable, immediate synchronized cardioversion. Use synchronized electrical cardioversion to reset the heart rhythm. The recommended starting energy level is 100 joules for biphasic devices. If the first shock fails, escalate the energy level for subsequent attempts. Sedation should be considered if time allows and the patient is conscious. If hemodynamically stable, antiarrhythmic therapy, amiodarone. The initial dose is 150 mg IV over 10 minutes, followed by a continuous infusion of 1 mg-min for 6 hours, then 0.5 mg-min for 18 hours. Alternatively, procainamide if no signs of heart failure, or lidocaine can be used for stable VT. Reevaluation: after treatment, continuously monitor the patient's ECG and vital signs to ensure stability and resolution of the arrhythmia. Definitive care: long-term management may include implantable cardioverter defibrillators, ICTs, or catheter ablation for patients with recurrent VT. VT can deteriorate into ventricular fibrillation. VF, which is a more lethal rhythm that requires immediate defibrillation. Therefore, time is of the essence in managing VT, especially if the patient shows signs of instability. What are the key steps in the ACLS algorithm for managing cardiac arrest due to VF pulseless VT? Answer: for cardiac arrest due to ventricular fibrillation, VF, or pulseless ventricular tachycardia (VT), the ACLS algorithm includes the following key steps. Initiate CPR. Start with high-quality CPR immediately, ensuring compressions are at least 2 inches deep and at a rate of 100-120 compressions per minute with minimal interruptions. Ensure proper ventilation with a bag-mask device providing 2 breaths after every 30 compressions, if not intubated. Defibrillation. Deliver a shock as soon as the defibrillator is ready. For biphasic defibrillators, the initial dose is 200 joules. For monophasic defibrillators, use 360 joules. Resume CPR immediately after the shock for another 2 minutes before reassessing the rhythm. Administer epinephrine. If the rhythm persists after 2 minutes of CPR and another defibrillation attempt, give 1 mg of epinephrine IV every 3-5 minutes. Epinephrine is a vasopressor that increases coronary and cerebral perfusion during CPR by causing peripheral vasoconstriction. Consider antiarrhythmic drugs. Amiodarone is the preferred antiarrhythmic drug if VF pulseless VT persists after 2-3 shocks. The first dose is 300 mg IV push, followed by 150 mg for a second dose if needed. Alternatively, lidocaine can be used if amiodarone is unavailable. Initial dose 1.5 mg IVO. Continue CPR and defibrillation cycles. Perform CPR for 2-minute intervals with rhythm checks and defibrillation. If VF pulseless VT persists after each cycle, maintain high-quality CPR throughout the entire resuscitation process. Identify and treat reversible causes. Consider potential reversible causes of the arrest, often summarized by the H's and T's. H's: hypoxia, hypovolemia, hydrogen ion acidosis, hypohyperkalemia, hypothermia. T's: tension, pneumothorax, tamponade. Cardiac: toxins, thrombosis, pulmonary or coronary. How do you identify pulseless electrical activity, P, on a CG, and what is the appropriate management strategy? Answer: magnesium sulfate is specifically indicated in ACLS for the treatment of Torsades points, a type of polymorphic ventricular tachycardia that is often associated with prolonged QT interval. It can also be used in cases of life-threatening ventricular arrhythmias due to hypomagnesemia. Torsades points. Magnesium sulfate is the first-line treatment even if the patient is not known to be hypomagnesemic. Dosage: for patients in cardiac arrest, administer 1-2 grams IVO diluted in 10 mml DW extras 5% over 5-2 minutes. For patients who are not in cardiac arrest, administer 1-2 grams IV over 5-6 minutes, followed by a maintenance infusion of 0.5-1 grammer to prevent recurrence. Mechanism of action: magnesium stabilizes cardiac cells by reducing the influx of calcium, which helps to prevent the early after depolarizations that can lead to Torsades points. Other indications: hypomagnesemia. Patients with low magnesium levels, often due to chronic conditions like alcoholism, malnutrition, or diuretic use, may experience arrhythmias. Magnesium can help correct these imbalances and restore normal heart rhythm. Magnesium is not a routine antiarrhythmic for other types of ventricular arrhythmias, but it is crucial for Torsades points and arrhythmias caused by electrolyte imbalances. What are the indications for the use of anticoagulation therapy in a patient with atrial fibrillation, and what scoring system is commonly used to assess stroke risk? Answer: for a stable patient with supraventricular tachycardia (SVT), the focus is on slowing the heart rate to convert the rhythm to sinus rhythm. The ACLS guidelines recommend the following approach: vagal maneuvers. Vagal maneuvers are the first step and can terminate up to 20% of SVT episodes by stimulating the vagus nerve, which increases parasympathetic tone and slows AV node conduction. Techniques include Valsalva maneuver: instruct the patient to bear down as if having a bowel movement for 1.15 seconds. Carotid sinus massage, performed by a healthcare professional by gently massaging one carotid artery to avoid in older patients or those with a history of carotid artery disease. If vagal maneuvers are effective, no pharmacological intervention may be necessary. Adenosine. If vagal maneuvers are ineffective, administer adenosine. Initial dose 6 mg IV push rapidly over 1-2 seconds, followed immediately by a flush of 20 ml saline. If the rhythm does not convert, a second dose of 12 mg IV can be given after 1-2 minutes. Mechanism of action: Adenosine temporarily blocks conduction through the AV node, interrupting the re-entry circuits that cause SVT. Calcium channel blockers, beta blockers. If adenosine fails or is contraindicated, e.g. in patients with asthma, calcium channel blockers such as diltiazem or verapamil, or beta blockers such as metoprolol may be used to slow V-node conduction. These medications are effective but work more slowly than adenosine. Electrical cardioversion. Synchronized cardioversion starting at 50,100 joules is used if the patient becomes unstable, hypotension, alter mental status during the SVT episode. Most cases of SVT can be managed successfully with vagal maneuvers and adenosine, but persistent or recurrent episodes may require further workup and treatment such as catheter ablation. Describe the management steps for a patient experiencing stable tachycardia. Answer: cardioversion and defibrillation are both techniques used to treat arrhythmias, but they are applied differently depending on the type of rhythm and the patient's condition. Cardioversion. Indication: cardioversion is used for hemodynamically unstable tachycardias with a pulse, such as atrial fibrillation, atrial flutter, supraventricular tachycardia (SVT), and stable ventricular tachycardia. Mechanism: cardioversion is synchronized to the patient's cardiac cycle, delivering the shock on the R wave of the QRS complex to avoid inducing ventricular fibrillation. Energy levels: for atrial fibrillation, start with 100-200 joules biphasic. For atrial flutter, start with 50-100 joules. For ventricular tachycardia with a pulse, start with 100 joules. Sedation: patients are typically sedated because cardioversion can be painful. Goal: the shock resets the heart's electrical activity, allowing normal sinus rhythm to resume. Defibrillation. Indication: defibrillation is used in cardiac arrest due to pulseless ventricular tachycardia or ventricular fibrillation. Mechanism: defibrillation is unsynchronized, meaning it delivers the shock at any point in the cardiac cycle because there is no organized rhythm to synchronize with. Energy levels: biphasic defibrillators typically use 200 joules for the initial shock. Monophasic defibrillators deliver 360 joules. Goal: the high-energy shock depolarizes the heart's electrical system completely, allowing the heart's natural pacemaker, the SA node, to take over and restore a normal rhythm. In summary, cardioversion is for patients with a pulse and tachyarrhythmias, while defibrillation is for cardiac arrest patients with no pulse. ECA patient with a systole: what are the initial steps in management according to ACLS guidelines? Answer: in cardiac arrest, epinephrine is administered as a vasopressor to improve coronary and cerebral perfusion during resuscitation. Dose: 1 mg IVO, push every 3-5 minutes during the resuscitation effort. Epinephrine should be given as soon as possible in a systole and pulseless electrical activity (P) and after the second defibrillation attempt in ventricular fibrillation (VF) or pulseless ventricular tachycardia (VT). Mechanism of action: epinephrine is a sympathomimetic drug that stimulates alpha-1 adrenergic receptors, causing vasoconstriction and increasing systemic vascular resistance. This improves perfusion pressure to vital organs, especially the heart and brain. It also stimulates beta-1 adrenergic receptors, increasing heart rate and myocardial contractility. Considerations: epinephrine should be administered as part of the overall resuscitation strategy, which includes high-quality CPR and timely defibrillation for shockable rhythms. While epinephrine can increase the likelihood of return of spontaneous circulation, ROSC's role in improving long-term survival and neurological outcomes remains under investigation. Epinephrine is a critical component of the ACLS protocol and should be given without delay in every cardiac arrest scenario. What role does effective communication play in the implementation of ACLS algorithms during a code situation? Answer: in the case of pulseless electrical activity (P), the heart displays an electrical rhythm on the monitor, but there is no detectable pulse, indicating the heart is not effectively pumping blood. Management: high-quality CPR should be initiated immediately. Epinephrine: give 1 mg IVO every 3-5 minutes during CPR. Do not defibrillate. P. A is not a shockable rhythm. Defibrillation is reserved for ventricular fibrillation (VF) or pulseless ventricular tachycardia (VT). Identifying reversible causes: the key to managing PA is identifying and treating the underlying cause. This is often summarized by the H's and T's. H: hypovolemia, hypoxia, hydrogen ion. Acidosis, hypohyperkalemia, hypothermia. T's: tension, pneumothorax, tamponade. Cardiac: toxins, thrombosis, pulmonary or coronary. Addressing these reversible causes is crucial for improving the chances of successful resuscitation. Post-CPR monitoring. After ROSC, continue to monitor for signs of the underlying cause and provide post-resuscitation care, including advanced airway management and targeted temperature management, TTM, if indicated. PA carries a high mortality rate, but addressing reversible causes can improve outcomes. Outline the key components of the ACLS algorithm for managing tachycardia with a pulse. Answer. Once return of spontaneous circulation (ROSC) is achieved after cardiac arrest, the focus shifts to post-cardiac arrest care to improve survival and neurological outcomes. The following components are essential in the management of post-cardiac arrest patients. Optimize hemodynamics. Blood pressure. Maintain systolic BP 9 mmHg and mean arterial pressure (MEWL 65 mmHg) to ensure adequate organ perfusion. Use IV fluids, normal saline or lactated ringers or vasopressors, e.g. norepinephrine, epinephrine, or dopamine if necessary to achieve target BP. Oxygenation. Ensure adequate oxygen delivery by maintaining oxygen saturation equals 74%. Avoid hyperoxia, which can cause oxidative stress. Advanced airway management. If not already established, consider advanced airway support with endotracheal intubation and controlled ventilation. Ventilator settings. Target an end tidal echo of 3-5 for RAHG and avoid hyperventilation, which can reduce cerebral perfusion. Electrolyte and glucose management. Correct electrolyte imbalances such as hyperkalemia, hypokalemia, or hypocalcemia. Maintain blood glucose levels within normal range. Hypoglycemia and hypoglycemia should both be avoided, as they can worsen neurological injury. Targeted temperature management, TTM. Also known as therapeutic hypothermia, TTM involves lowering the patient's body temperature to 360 for at least 24 hours to protect the brain and other organs from reperfusion injury after ROSC. TTM is recommended for patients who remain comatose after cardiac arrest, regardless of the initial rhythm, shockable or non-shockable. Neurological monitoring. Continuous EEG monitoring may be required to detect seizures, especially in comatose patients. Perform regular neurological assessments to monitor recovery. Brain imaging, ET or MRI, might be needed to assess potential brain injury. Explain the differences between the primary and secondary surveys in the initial assessment of a patient experiencing cardiac arrest. Answer. The initial assessment consists of two key surveys. Primary survey ABC. Airway. Ensure the airway is open. If the patient is unresponsive, utilize maneuvers such as the head tilt, chin lift, or jaw thrust to maintain airway patency. Breathing. Assess for effective ventilation. If not breathing, provide rescue breaths if trained, or initiate CPR. Circulation. Check for a pulse. If there is no pulse, commence high-quality CPR immediately. Secondary survey. Conduct a detailed history and physical examination to identify possible causes of the cardiac arrest, such as previous medical conditions, medications, and any recent changes in health. Relevant guidelines. AHA emphasizes that the primary survey should be conducted rapidly with a focus on immediate interventions to restore airway, breathing, and circulation, while the secondary survey allows for a more thorough assessment. Describe the components of high-quality CPR and explain why each component is essential for effective resuscitation. Answer. High-quality CPR involves the following components. Minimizing interruptions. Continuous compressions should be prioritized. Interruptions in chest compressions can adversely affect perfusion pressure and decrease survival rates. Proper technique. Compressions. Use the heel of one hand on the lower half of the sternum, with the other hand on top, keeping elbows straight. The compression rate should be 100-120 compressions per minute, with a depth of at least 2 inches 5 centimeters for adults. Ventilations. If providing rescue breaths, give 2 breaths after every 30 compressions, ensuring adequate chest rise. Feedback devices. Utilize devices that provide real-time feedback on compression depth and rate to ensure quality assurance. Relevant guidelines. AHA guidelines stress that high-quality CPR is the cornerstone of resuscitation, significantly impacting the chances of survival and favorable neurological outcomes. ECA Resuscitation Team. What roles and responsibilities should team members have, and how can effective communication enhance the resuscitation efforts? Answer. In a resuscitation team, clear roles and responsibilities include team leader, manages the overall resuscitation effort, makes critical decisions, and delegates tasks. Compressor, performs chest compressions, focusing on high-quality CPR. Ventilator, administers rescue breaths if applicable. Recorder, keeps track of time and medications administered, ensuring proper documentation of the resuscitation process. Effective communication, closed-loop communication. Team members should use clear, concise communication and confirm understanding e.g., I will administer 1 mg of epinephrine. Regular updates. The team leader should provide continuous updates on the patient's status and any changes in treatment protocols. Relevant guidelines. According to AHA, effective team dynamics and communication are critical for improving the chances of successful resuscitation and minimizing errors during the process. Mr. Smith, a 62-year-old man, suddenly collapses at a family gathering. Upon checking, you find him unresponsive and not breathing. What immediate actions should you take and what protocols should you follow according to ACLS guidelines? Answer: call for help. Immediately call 911 or have someone call for emergency assistance. Ensure that an automated external defibrillator (ED) is fetched if available. Check responsiveness and breathing. Shake Mr. Smith gently and shout, "Are you okay?" If he does not respond and is not breathing normally or only gasping, proceed to the next steps. Initiate CPR. Begin high-quality chest compressions at a rate of 1:0.012 compressions per minute with a depth of at least 2 inches. After 30 compressions, open the airway using the head tilt chin lift maneuver and deliver 2 rescue breaths if trained and equipped. Continue CPR. Perform cycles of 30 compressions and 2 breaths until emergency responders arrive or an AED is available. Use the ED as soon as the AED arrives. Turn it on and follow the voice prompts. Relevant guidelines. According to AHA protocols, immediate recognition and intervention are crucial for improving survival rates in cardiac arrest scenarios. What are the essential components of post-cardiac arrest care and why is continuous monitoring crucial? Answer: post-cardiac arrest care includes early intervention, rapid initiation of targeted temperature management if indicated, alongside continuous monitoring of vital signs. Goals of care: neurological stability, ensuring adequate cerebral perfusion is critical. This may involve optimizing oxygenation and circulation. Hemodynamic stability, monitoring blood pressure, heart rate, and rhythm is vital for assessing overall stability. Continuous monitoring. It is essential to continuously monitor neurological status, hemodynamics, and biochemical markers like lactate levels to detect complications early. Relevant guidelines. The AHA emphasizes that comprehensive post-cardiac arrest care is essential for improving neurological outcomes and survival rates, focusing on maintaining stability in the hours and days following the event. Discuss the pharmacological agents commonly used during cardiac arrest and the rationale behind their use. Answer: common pharmacological agents used during cardiac arrest include epinephrine, administered at a dose of 1 mg, 110-0 solution every 3-5 minutes during resuscitation to increase coronary and cerebral perfusion pressure. Amiodarone, administered for refractory ventricular fibrillation, pulseless ventricular tachycardia at a dose of 300 mg, followed by 150 mg if needed. Atropine, used for symptomatic bradycardia, administered at 0.5 mg IV every 3-5 minutes, maximum total dose of 3 mg. Rationale: these medications work by improving perfusion and restoring normal cardiac rhythm during critical moments of resuscitation. Relevant guidelines. AHA guidelines outline the specific protocols for medication administration during cardiac arrest to maximize chances of successful resuscitation. What are the classic signs and symptoms of acute coronary syndrome (ACS), and how can these symptoms differ between ST, MI, and NST, MI? Answer: the classic signs and symptoms of ACS include chest pain, often described as pressure, squeezing, or fullness that may radiate to the arm, neck, jaw, or back. Shortness of breath can occur with or without chest discomfort. Diaphoresis, profuse sweating, often associated with a feeling of impending doom. Nausea and vomiting, commonly reported by patients experiencing an ACS event. Differentiating ST, MI from NSTEMI. Centralization myocardial infarction (STEMI), characterized by a complete blockage of a coronary artery, evidenced on a 12-lead ECG by segment elevation in contiguous leads. Symptoms tend to be more severe and there is a greater risk of complications. Non-centralization myocardial infarction (NSTEMI), caused by partial blockage of a coronary artery with segment depression or T-wave inversions on the ECG. Symptoms may be less intense, but the risk of myocardial damage is still significant. In the management of ACS, why is time to treatment critical, and what are the recommended time frames for intervention? Answer: time to treatment in acute coronary syndrome (ACS) is critical because the heart muscle is highly sensitive to ischemia, meaning that prolonged deprivation of oxygenated blood leads to irreversible myocardial damage. This is encapsulated by the phrase "a time is muscle." For every minute that passes without restoring blood flow to the ischemic area, more heart tissue becomes necrotic, increasing the likelihood of complications such as heart failure, arrhythmias, or death. In the case of St. elevation myocardial infarction, STEMI, where there is a complete blockage of a coronary artery, immediate reperfusion therapy is essential. The recommended time frame for primary percutaneous coronary intervention (ECI) is within 90 minutes of first medical contact. This is referred to as the daughter ballooner time and is critical for optimal outcomes. If PCI is unavailable within this time frame, fibrinolytic therapy should be considered, ideally administered within 30 minutes of arrival. A daughter needle time. The overall aim is to initiate therapy within 120 minutes of symptom onset. For non-St. elevation myocardial infarction (NSTEMI), the urgency is slightly reduced because there is only partial blockage. Nonetheless, high-risk patients, based on clinical presentation, ECG changes or biomarkers, should receive PCI within 2 hours. Early identification and risk stratification of NSTE-MI patients are crucial to prevent progression to full infarction. What is the importance of 12-lead ECG interpretation in the assessment of ACS, and what key changes should clinicians look for? Answer: the 12-lead ECG is a fundamental tool in diagnosing acute coronary syndrome acts, as it provides a quick, non-invasive method to assess the electrical activity of the heart and detect ischemia or infarction. The ECG offers critical insights into which region of the heart is affected, allowing for targeted intervention and timely treatment. In St. elevation myocardial infarction (STEMI), clinicians look for St. segment elevation in 2 or more contiguous leads, which indicates a complete coronary artery occlusion. The location of the St. elevation helps localize the infarction. For example, elevations in leads VV suggest an anterior wall MI, likely involving the left anterior descending artery, while elevations in leads II and AF point to an inferior wall MI, likely involving the right coronary artery. In non-St. elevation myocardial infarction (NSTEMI) or unstable angina, the CG may show St. segment depression or T-wave inversions, which suggest subendocardial ischemia due to partial coronary artery obstruction. These changes can fluctuate or normalize, so continuous or serial ECGs are often needed to monitor evolving ischemia. What are the inclusion and exclusion criteria for administering fibrinolytics in the setting of STE-MI? Provide examples of both. Answer: the 12-lead ECG is a fundamental tool in diagnosing acute coronary syndrome acts, as it provides a quick, non-invasive method to assess the electrical activity of the heart and detect ischemia or infarction. The ECG offers critical insights into which region of the heart is affected, allowing for targeted intervention and timely treatment. In St. elevation myocardial infarction (STEMI), clinicians look for St. segment elevation in 2 or more contiguous leads, which indicates a complete coronary artery occlusion. The location of the St. elevation helps localize the infarction. For example, elevations in leads VV suggest an anterior wall MI, likely involving the left anterior descending artery, while elevations in leads II and AF point to an inferior wall MI, likely involving the right coronary artery. In non-St. elevation myocardial infarction (NSTEMI) or unstable angina, the CG may show St. segment depression or T-wave inversions, which suggest subendocardial ischemia due to partial coronary artery obstruction. These changes can fluctuate or normalize, so continuous or serial ECGs are often needed to monitor evolving ischemia. Explain the pharmacologic treatment options for ACS, particularly focusing on antiplatelet therapy and anticoagulation. How do these therapies differ in their mechanisms of action? Answer: antiplatelet therapy aspirin inhibits cyclooxygenase 1, COX-1, reducing thromboxane production, thereby inhibiting platelet aggregation. Clopidogrel, a pyroreceptor inhibitor, preventing AT-mediated activation of platelets, further reducing the risk of clot formation. Ticagrelor, another PI inhibitor that acts more rapidly and reversibly compared to clopidogrel, providing quicker antiplatelet effects. Anticoagulation options. Heparin works by potentiating antithrombin II, leading to an activation of thrombin and factors R, thereby preventing further clot formation. Enoxaparin, a low molecular weight heparin that predominantly inhibits factors R with a more predictable anticoagulant response, allowing for outpatient management. What are the recommended timing and technique for performing percutaneous coronary intervention (ECI) in patients with STE-MI? Answer: the recommended timing for PCI in STE-MI patients is ideally within 90 minutes of first medical contact. The technique involves access site selection, usually femoral or radial artery access for catheter insertion, coronary angiography, visualization of coronary arteries to identify occlusions, balloon angioplasty, inflation of a balloon at the site of the blockage to restore blood flow, stenting, placement of a drug-eluting stent to maintain artery patency and reduce the risk of restenosis, post-procedure management, monitoring for complications and ensuring proper antiplatelet therapy is maintained. Put PCI. Effective and timely PCI significantly improves outcomes for STE-MI patients by limiting myocardial damage. What are the critical components for recognizing cardiac arrest in an adult patient? Answer: ethical considerations in resuscitation play a vital role in guiding healthcare providers, particularly in the context of patient autonomy, consent, and quality of life. Patient autonomy. Respecting the patient's wishes is a cornerstone of medical ethics. If a patient has a do not resuscitate DNR order or an advance directive, healthcare providers must honor it even during a critical event like cardiac arrest. It is unethical to provide resuscitation if a valid DNR exists, as it violates the patient's previously expressed wishes. Informed consent. In an emergency, obtaining consent may not always be feasible. If the patient is incapacitated and no advance directive is present, the healthcare provider must act in the patient's best interest, assuming implied consent for life-saving treatment. However, efforts should be made to clarify the patient's wishes as soon as possible, either through family members or legal documents. Quality of life. The ethical principle of beneficence involves doing what is best for the patient, while non-maleficence focuses on preventing harm. In some cases, resuscitation might restore circulation, but the patient may survive with severe neurological impairment or in a persistent vegetative state. In these instances, providers must consider whether the resuscitation efforts will result in an acceptable quality of life for the patient. What ethical considerations should be taken into account during resuscitation efforts, particularly concerning patient autonomy and consent? Answer: ethical considerations in resuscitation play a vital role in guiding healthcare providers, particularly in the context of patient autonomy, consent, and quality of life. Patient autonomy. Respecting the patient's wishes is a cornerstone of medical ethics. If a patient has a do not resuscitate DNR order or an advance directive, healthcare providers must honor it even during a critical event like cardiac arrest. It is unethical to provide resuscitation if a valid DNR exists, as it violates the patient's previously expressed wishes. Informed consent. In an emergency, obtaining consent may not always be feasible. If the patient is incapacitated and no advance directive is present, the healthcare provider must act in the patient's best interest, assuming implied consent for life-saving treatment. However, efforts should be made to clarify the patient's wishes as soon as possible, either through family members or legal documents. Quality of life. The ethical principle of beneficence involves doing what is best for the patient, while non-maleficence focuses on preventing harm. In some cases, resuscitation might restore circulation, but the patient may survive with severe neurological impairment or in a persistent vegetative state. In these instances, providers must consider whether the resuscitation efforts will result in an acceptable quality of life for the patient. Explain the protocols for defibrillation during a cardiac arrest scenario and the significance of timing in delivering shocks. Answer: defibrillation is one of the most effective treatments for ventricular fibrillation, VF, and pulseless ventricular tachycardia, VT, both life-threatening rhythms commonly associated with cardiac arrest. Successful defibrillation depends on proper rhythm recognition and timely intervention. Rhythm analysis. After identifying cardiac arrest and starting CPR, it is essential to perform a rhythm check as soon as a defibrillator or automated external defibrillator is available, using either manual defibrillation in the case of trained personnel or an AED. The device will analyze the heart rhythm and indicate whether shock is advised. Shockable rhythms. VF and pulseless VT are shockable rhythms. When these rhythms are detected, defibrillation should be performed immediately. Modern defibrillators deliver biphasic shock. Recommended initial energy dose between 120 200 joules. If the first shock is unsuccessful, continue with 2 minutes of high-quality CPR before reanalyzing the rhythm. Timing. The timing of defibrillation is crucial. For every minute that passes without defibrillation, the likelihood of survival decreases significantly. Immediate defibrillation within the first few minutes of cardiac arrest can increase survival rates by up to 70%. Defibrillation works by stunning the heart, momentarily stopping its chaotic electrical activity, allowing it to restart in a normal rhythm. Post-defibrillation, continuous monitoring and CPR should resume immediately, followed by subsequent rhythm checks and possible additional shocks as necessary. Following the AHA guidelines and ensuring rapid defibrillation significantly improves patient survival in cardiac arrest cases. Discuss the special considerations that must be taken into account when providing care for pediatric patients in cardiac arrest situations. Answer: pediatric resuscitation requires unique considerations due to the anatomical and physiological differences between children and adults, as well as the emotional and psychological aspects of treating younger patients. Anatomical differences. Children have smaller airways, which makes airway management more delicate. They are more susceptible to airway obstruction, so techniques like jaw thrust or head tilt chin lift must be applied carefully. Additionally, chest compressions in infants and young children are performed using 1 or 2 fingers for infants and 1 or 2 hands for children, with a depth of about 1.5 inches, 4 centimeters for infants and 2 inches, 5 centimeters for children. Physiological differences. The causes of cardiac arrest in children are often respiratory rather than cardiac, unlike in adults. Therefore, effective management of pediatric cardiac arrest often requires a focus on airway and breathing issues such as early intervention for respiratory distress or failure. Hypoxia is a common cause of cardiac arrest in children, so ensuring proper oxygenation and ventilation is critical. Dosage calculations. Drug dosages for resuscitation in children are calculated based on weight, usually at 0. mg for epinephrine and for mdg for amiodarone during advanced life support. Accurate weight-based calculations ensure that children receive appropriate doses that align with their smaller body size and metabolic needs. Emotional considerations. Pediatric cardiac arrest is highly distressing for both healthcare providers and family members. It is important to involve the family, providing clear communication and support during and after the resuscitation process. Studies have shown that allowing family members to be present during resuscitation may provide comfort and closure, though this should be handled sensitively. The Pediatric Advanced Life Support (PALS) guidelines emphasize the importance of early recognition of respiratory distress and proper airway management in preventing pediatric cardiac arrest, alongside appropriate pharmacological and emotional care tailored to children's unique needs. What are the inclusion and exclusion criteria for administering fibrinolytics in the setting of ST-MI? Provide examples of both. Answer: fibrinolytic therapy is a critical intervention in the treatment of ST-MI when percutaneous coronary intervention (ECI) is unavailable or delayed beyond recommended time frames. However, it carries significant risks, primarily the potential for life-threatening bleeding, so careful patient selection is crucial. Inclusion criteria for fibrinolytics include presentation with STEMI. Specifically, patients must have segment elevation in 2 or more contiguous leads or new left bundle branch blur BB. Symptom onset within 12 hours. Fibrinolytic therapy is most effective when given within this time window. Beyond 12 hours, the benefits decrease as more myocardial tissue becomes necrotic. Patients who cannot receive timely PCI, if an equipable facility cannot provide intervention within 120 minutes of first medical contact, fibrinolytics are indicated. Exclusion criteria are designed to minimize the risk of catastrophic bleeding and include previous intracranial hemorrhage or known structural cerebral vascular abnormalities, e.g. aneurysms, active internal bleeding, excluding menses, or recent major surgery or trauma within 2-4 weeks. Uncontrolled hypertension, systolic blood pressure over 108 mmHg or diastolic blood pressure over 100 mmHg presence, a significant bleeding risk. Recent ischemic stroke. Fibrinolytics are contraindicated if a stroke occurred within the past 3 months. These criteria reflect a balance between the need for rapid myocardial reperfusion and the risk of bleeding, particularly intracranial hemorrhage, which can be fatal. Discuss the role of cardiac catheterization in ACS management. What are the indications for this intervention? Answer: cardiac catheterization plays a central role in the management of acute coronary syndrome (ACS), especially in patients with central elevation myocardial infarction (STEMI) and high-risk non-central elevation myocardial infarction (NSTEMI). This procedure allows direct visualization of the coronary arteries to identify blockages and facilitates intervention through percutaneous coronary intervention (ECI). The primary indication for cardiac catheterization in ACS is ST-MI, where urgent PCI can restore blood flow to the myocardium and minimize tissue damage. Guidelines recommend that ST-MI patients undergo catheterization and PCI within 90 minutes of arriving at the hospital or door to balloon time. In cases where a hospital cannot provide PCI, cardiac catheterization should be performed immediately after fibrinolytic therapy if successful reperfusion is not achieved or signs of re-occlusion occur. For NSTE, MI indications for early cardiac catheterization include patients with persistent chest pain or ischemic symptoms, dynamic segment or T-wave changes, elevated troponin levels indicating myocardial injury, hemodynamic instability or heart failure. Cardiac catheterization can also be used in unstable angina for high-risk patients as well as for those who remain symptomatic despite optimal medical management. Through catheterization, clinicians can decide whether angioplasty, stent placement, or coronary artery bypass surgery (CABG) is necessary, allowing for tailored treatment that significantly improves outcomes in ACS patients. What are the non-pharmacological interventions available for managing ACS, and how do they complement pharmacological treatments? Answer: non-pharmacological interventions for acute coronary syndrome (ACS) are essential components of comprehensive care that complement pharmacological therapies, addressing the underlying pathophysiology and improving long-term outcomes. The most significant non-pharmacological intervention is percutaneous coronary intervention (ECI). PCI involves threading a catheter into the coronary arteries, inflating a balloon to open the blocked artery, balloon angioplasty, and often placing a stent to keep the artery open. PCI is the preferred treatment for STE, MI and high-risk NSTE, MI patients, providing immediate relief from ischemia and reducing the risk of heart failure or death. Other non-pharmacological strategies include lifestyle modifications. Long-term management includes advising patients on smoking cessation, adopting a heart-healthy diet, low in saturated fats and cholesterol, regular physical activity, and weight management. These modifications help prevent future cardiac events by addressing key risk factors like hypertension, hyperlipidemia, and diabetes. Cardiac rehabilitation, a structured program that incorporates monitored exercise, education on heart disease management, and psychological support. This program helps patients recover post-ACS, reduces hospital readmissions, and improves survival rates. Coronary artery bypass grafting (CABG) for patients with severe multivessel disease or complex coronary anatomy unsuitable for PCI, CABG is a surgical alternative that restores blood flow by bypassing blocked arteries using grafts. These non-pharmacological interventions work alongside medications like antiplatelets, anticoagulants, and statins to reduce further ischemic events and improve the quality of life post-ACS. Describe the importance of risk factor identification in the assessment of high-risk patients for ACS. What factors should clinicians prioritize? Answer: risk factor identification is critical in the prevention, diagnosis, and management of acute coronary syndrome (ACS because it helps clinicians stratify patients' risk levels, predict outcomes, and tailor individualized treatment plans. By understanding a patient's risk profile, clinicians can implement preventive strategies or decide on more aggressive treatment for high-risk patients. Clinicians should prioritize the following non-modifiable and modifiable risk factors. Age: men over the age of 45 and women over 55 have an increased risk of ACS due to age-related changes in blood vessels, including atherosclerosis. Family history: a family history of premature coronary artery disease (CAD), especially in first-degree relatives, is a significant risk factor as it suggests a genetic predisposition to heart disease. Diabetes mellitus: patients with diabetes have an accelerated risk of coronary artery disease due to endothelial dysfunction and increased atherogenesis. Aggressive glucose control and management of other risk factors are crucial. Hypertension: high blood pressure damages blood vessels over time, making them more prone to atherosclerotic plaque buildup, leading to ACS. Blood pressure control is essential in reducing ACS risk. Hyperlipidemia: elevated levels of LDL cholesterol and low levels of HDL cholesterol promote plaque formation. Lipid-lowering therapies, particularly statins, are essential in high-risk patients. Smoking: tobacco use is a significant modifiable risk factor for ACS as it promotes endothelial damage, inflammation, and plaque formation. Smoking cessation is a priority in risk reduction. Obesity and sedentary lifestyle: excess weight, particularly central obesity, is associated with insulin resistance, dyslipidemia, and hypertension, all contributing to ACS risk. Promoting a healthy lifestyle through diet and exercise can significantly reduce this risk. Chronic kidney disease (CKD): patients with CKD are at higher risk for ACS due to the complex interplay of hypertension, hyperlipidemia, and increased atherosclerosis in kidney disease. By addressing these risk factors, clinicians can improve preventive care, guide therapeutic decisions, and ultimately reduce the incidence of ACS events in high-risk populations.